Hello everyone, welcome back to Radiology. My name is Dr. Andras Seke, and today I am going to talk to you about the chest and cardiothoracic imaging. First of all, let me ask you, what is wrong with this chest X-ray? I think it's quite obvious that this patient left his or her necklace on, so this image is actually not useful. If you see this, you should definitely ask for a repeat. Now, have you ever wondered how fast an expert radiologist can recognize a lesion on a chest X-ray? It turns out that it's actually less than 1 second in which an expert can recognize about 70% of lesions on a PA chest X-ray. And that has to do with the fact that expert radiologists are quite used to looking at chest X-rays and used to looking at the normal. So when they are seeing something abnormal, it sort of stands out unconsciously, and that's why it's so fast. Now, I have given you about 10 to 15 seconds to look at this image, and I hope that many of you have recognized that something is abnormal on the image. There's actually a rounded opacity with sharp contours that is projecting on the heart. You can see it over here, and I have made a drawing here. So there's actually an air fluid level within this lesion, and this is diagnostic for a hiatal hernia. We as doctors need to be familiar with the normal two-way chest X-ray, so with the PA and with the lateral. It doesn't matter if you're a radiologist, a pulmonologist, or a pediatrician, you need to be able to recognize the normal anatomy. So starting from left top, we see an added opacity next to the trachea, which is made up by the great vessels and the right paratracheal fat. We call this a stripe, and the superior vena cava. And then as you come down, the azygous vein makes this contour over here. And then as we go further down, there is again the superior vena cava, and that goes into the right atrium. Much of the heart's shadow is made up by the right atrium, as you can see it over here. And then below that, there is again either a fat bed or the shadow of the inferior vena cava. On the left, again, we see this opacity caused by the great vessels and some fat. And then comes the aortic arch, then the main pulmonary artery, then the auricle of the left atrium, and then finally the left ventricle. Next to the apex of the heart, sometimes there is a fat bed, which correlates well with obesity. Now, if you're looking at a chest X-ray, you're looking at a lot of air, some vessels, some bronchi. Therefore, the lung itself is transparent or black on the chest X-ray. On the right image, you can see the projection of the heart and the great vessels, and you can see again that much of the heart's shadow on the right is made up by the right atrium, and the right ventricle causes the shadow of the heart in the middle and even on the left. The normal lateral chest X-ray looks like this, where you have an anterior clear space. This is called the retrosternal clear space, and behind the heart is the retrocardiac clear space. You can see the vertebral bodies, and you might also be able to see that they become more and more transparent as we go from top to bottom, because up here at the top there are a lot of things that are overlapping, like the shoulders, a lot of muscles, maybe some fat as well, which cause the X-ray photons to lose a lot of their energy. So this part of the image remains white, and down here where the photons travel through just a lot of air, the pixels become black, so this area becomes transparent or dark. Now over here you can see that behind the sternum the right ventricle projects, and then you can see the pulmonary outflow tract, and then the ascending aorta, and on the top in the midline you can see this column of air which is caused by the trachea. The trachea divides up at around here, and you can see two smaller air columns which are caused by the left and main bronchi. Below them you see the left atrium, and even further down the left ventricle, and again below the heart there's an increased opacity which is caused by either some fat or the inferior vena cava. And if you look onto this right image, you can again see the projection of the heart and the great vessels as they appear on the lateral chest x-ray. So how do we approach the chest x-ray? Now, the good answer to this question is that no matter how you do it, you should do it the same way every time you're looking at a chest x-ray, otherwise you're going to miss lesions. The way I do it, I always start at the diaphragm, then I move on to the claustrophenic angles, then I compare the lungs and the lung parenchyma in particular. That way I may be able to spot some round lesions or infiltrations, cancers, etc. Then I look at the tracheal air column and the mediastinal structures, including the heart. Then I compare the right and the left hyla. And last but not least, you should always look at the bones and the soft tissues because there are a lot of them. Some lesions might hide at the lung bases, and you can imagine that a lot of lung is actually below this projected line of the diaphragm. So the lung probably ends right about here on the right. So lesions can hide in the lung bases, which you cannot see on the PA, or in the apices, in the large airways, in the mediastinum and the hyla, behind the heart, and again the bony structures and the upper abdomen are regions where non-expert readers might not look at. Here are the solutions to these numbers, which you can look at on your own. Now, it's very, very important for patients to take in a deep breath and hold it at the time of examination, because if they happen to blow out the air from their lungs when the image is taken, then the diaphragm will rise up, the basal segments will collapse, and you might mistake this area either for a consolidation or fibrosis or something other than normal lung tissue. But if the patient inhales properly, then you can see that these basal segments remain transparent, and so you will not mistakenly make a wrong diagnosis. Now, here are some classic chest x-ray signs which I think every medical doctor should be familiar with. First of all, the bright white line of a pneumothorax, which you can see here, highlighted by these yellow arrows as well. So if you see a bright white line beyond which there are no lung markings, and you can see that between these ribs all you can see is just black and no lung markings, then this is a pneumothorax. The deep sulcus sign, which is for a supine image, because in a supine image air doesn't necessarily rise up to the apices. If the patient is supine, then the highest point of the chest will be the anterior basal segments, and so much of the air will collect down here around the diaphragm, and air in the pleural cavity will cause an apparent deepening of the sulcus on the ipsilateral side of the pneumothorax. Now, if there is air and fluid in the pleural cavity, then you will see an air fluid level. Over here towards the midline, you can see the totally, completely collapsed lung, above which there is a lot of air, and below this horizontal line, there is this homogeneous opacity caused by a lot of blood. On the right image, for one, you can see a lot of air in the soft tissues. That's why there is this haziness around both apices and in the soft tissues. But that air had to have come from a pneumothorax, and that air dissected through the mediastinum and actually got into the mediastinum, and from the mediastinum it went up into the neck area and caused the surgical or subcutaneous emphysema. Now, if there's air in the mediastinum, then that might give rise to the so-called continuous diaphragm sign. When air gets in to between the heart and the diaphragm, it'll separate them, and so that's called the continuous diaphragm sign. Pleural effusion on a standing patient will form a meniscus that you can see on this left image in the left lung. These arrows are pointing to this classical meniscus sign, which is caused by pleural effusion. Now, if the patient is supine, then the fluid will have a chance to spread out and it'll cause diffuse haziness. And that's what you can see on this right side image. In the right lung or over the right lung, there is this diffuse haziness caused by pleural effusion. Infiltration, as in right upper lobe pneumonia, you can see that over here. Pneumonia classically, lobar pneumonia classically doesn't get into the bronchi, and so the bronchi will remain air-filled, thus they will remain black on the image. But the pneumonia, the infiltrate, will become white, and this is called an air bronchogram sign. Another classical appearance of pneumonia is bronchopneumonia, where you have multifocal disease, which is patchy because it gets into the bronchi and it can spread literally anywhere in the lung. And sometimes when pneumonia forms an abscess, then you will see again an air fluid level, just like we saw in hydropneumothorax. But this is an inflammation, a pneumonia, and so if you see an air fluid level within a pneumonia, then that's an abscess, and that's a classic basket with a handle sign. Neoplasms. On the left image, you can see the classic golden S sign, which is caused by a central mass that's sitting in the right hilum. And since it's compressing the right upper lobe bronchus, the right upper lobe is completely atelectatic. That's what you see above the mass, which is this white area over here. And if you are only focusing on the edge of the atelectatic right upper lobe and the edge of the mass, then this will give this reverse S or golden S sign as it is known in radiology. On the right image, you can see a peripheral cancer also sitting in the right upper lobe, but it gave rise to ipsilateral hilar lymphadenopathy, as it is indicated by this white arrow. Some more neoplasms. The Pancoast tumor, in this case a left apical tumor, is quite characteristic and obvious. It usually causes bony destruction, and sometimes we will see a central mass which is not that obvious on this chest x-ray, but if you are looking at the coronal CT, then you can see that in the probably the right upper lobe again, connecting to the hyla, there is this inhomogeneous gray central mass. Let's focus on the heart for a couple seconds. The heart has a typical shape as you have seen it about 10 slides back. Now, if there is left atrial enlargement, then instead of being concave, the left atrium becomes convex, so it's pointing or curving outwards from the hyla. And if it becomes that big, then the edge of the left atrium will become visible on the right hand side. That's what this second line is showing you. If there is considerable amount of pericardial effusion, then the heart will assume this soccer ball shape, but it is quite rare. Cardiac insufficiency has, again, classic signs on the chest x-ray, and depending on how severe the insufficiency is, the more of these signs we will see. So suppose the patient has left-sided heart failure, and so that'll increase the pressure within the left atrium. Now, the pressure in the left atrium can be measured indirectly with a Schwann-Ganz catheter. So you stick the catheter into a vein, put it into the right atrium, right ventricle, pulmonary artery, and you will place it in a capillary, and we will inflate a balloon, and that'll allow us to measure the pressure within that capillary. But that almost exactly matches the pressure in the left atrium. And this is what a Schwann-Ganz catheter looks like on a chest x-ray. This catheter was placed from the left subclavian vein, and as you can see, it was moved into the right atrium, the right ventricle, and then it goes up into the main pulmonary artery, and then it, in this case, the tip ends up on the right in a smaller capillary, not too far from the hyla. So the normal value of the pulmonary pressure is between 6 to 12, and so if the pressure increases, then we will see cephalization, perihilar haze, curly A and B lines, etc. Let me show you that on a chest x-ray. So first of all, we will see the meniscus sign, as you have seen before. This is indicating pleural effusion. We will see curly B lines, which are short and perpendicular to the pleura. The curly A lines are thicker lines. They originate from the hyla, and they go toward the periphery, but they never reach the periphery. The perihilar haze is sort of like a ground glass opacity that's overlapping the hilar area. Peribronchial cuffing is like you're looking at a bronchus which has a thicker wall, but this is not wall thickening. This is just the interstitium that's surrounding the bronchi, which contains lymphatics. And of course, if you have insufficiency, then a lot of fluid remains back in the lung and in the lymphatics of the lung, and so the interstitium thickens, and your eyes will see that as apparent bronchial wall thickening, but we call that peribronchial cuffing. Now, normally when the pressures are normal in the lung, then a lot of these veins in the upper lobes or in the upper third of the lung are not really open because all of the blood within them will go down obeying gravity and will end up in the lung. However, if the pressure is too high and the heart cannot properly clear away the blood from the lung, then naturally these veins have to open up. So we call that cephalization, when these upper lobe veins will open up and they will appear thicker to our eyes. If you're still confused about chest radiography, then I invite you to take my course. It is Fundamentals of Chest Radiography, which is going to be a 6-week course, and it's an English course. Here you can find a URL, or you can use this QR code, and you need to add yourself to this course if you want to get credit. So first of all, you need to enroll in Neptune and then add yourself on e-learning, and the password on e-learning is chest 2002, and then we can continue the discussion on that website. Let's now move on to chest pain. Chest pain can either be cardiac or non-cardiac. Within the cardiac group, we have ischemic and non-ischemic causes like angina, myocardial infarction, pericarditis, etc. On the non-cardiac group, we have the GI and the non-GI causes like pneumonia, pneumothorax, etc. The three most important of these are myocardial infarction, pulmonary embolism, and aortic dissection. And here are some of the tools that we can use for imaging these diseases. But instead of reading through these, let's now dig into the different diagnostic modalities. So we have CT coronarography, which is done with at least a 16-slice CT scanner, and beta blockers are frequently administered because we don't want the patient's heart to be beating too fast. This type of imaging can be either done prospectively or retrospectively, but the key is that it has to be done during diastole, when the heart is almost not moving at all. When you're doing retrospective CT imaging, then the CT X-ray source and the detector are continuously on. They are collecting data, and then the machine goes back and only uses the information that was done during diastole. So this means that the patient is receiving a much higher dose than when the imaging is done prospectively. In prospective imaging, the CT machine listens to the ECG reading and only starts gathering information when the heart is precisely in diastole. This means that the patients are receiving much less radiation. This type of imaging is good to assess anatomy of the heart and the coronaries, to identify and measure calcification. You might have heard about the calcium scoring, which can be calculated for each coronary artery based on the size and the density of the regions that are thought to contain calcium. Now, the calcium score doesn't directly relate to the narrowing of the vessels, but statistically it correlates well with the risk of cardiac disease, coronary artery disease, and myocardial infarction. So we use CTA or CTC, coronarography, if our patient has a non-acute chest pain, or if he or she has unsure or normal echocardiography findings, or if the treadmill or functional test results are not certain. So that's when we use CTC. Catheter angiography, you're probably familiar with by now. That's when patients are catheterized through one of their larger arteries, either through the leg or through the arm, and then the catheter is advanced into one of the coronaries. An iodine-based contrast media is used to visualize the coronaries. You can see over here on the left that this coronary has a narrowing in the middle third, and that's actually visualized even better on the computer-generated image. And with the computer-generated image, we can actually calculate the length and the percentage of the stenosis, so we can better assess the situation and we can better plan for stenting. Cardiac MR is a very, very powerful technique, but it needs a high-powered MR scanner, and it requires even better breath control from the patient's part and ECG gating. It's the best to assess the anatomy of the heart and the chambers. We can even image the aorta and the great vessels with it. We can visualize wall motion abnormalities, intraluminal structures, etc. Again, instead of reading the slides, let me show you 3 cases that demonstrate the power of cardiac MR. So let's suppose that a patient comes to the ER with sudden chest pain, and since he or she is older, then invasive coronarography is done, but let's suppose that the result comes back as negative. Now that can happen quite easily in cases when between the sudden onset of pain and the coronarography, the underlying cause is resolved. So look at the top right image, the moving image. That's how actually radiologists read these cases. First of all, they look at the moving images and they try to assess for wall motion abnormalities, and the blue arrow is pointing to a segment on the heart which is thinner and it's not moving that well. So then next we will look at the T2 weighted image, and you remember from the first talk that I told you that on the T2, things that contain a lot of water, so areas of edema, will light up quite bright. So the area that looks a little bit lazy on the sign image has a lot of edema in it, which is not good. And then what we do, because up to now the suspicion of an infarct is quite high, but we need to prove it. And the way to prove it is to give the patient contrast. And from the time of giving the contrast and the time of imaging, usually a 15-minute period passes, because the idea is that normal cells and actually normal cells will take up the contrast material, but since cardiac muscle has a lot of blood going in and a lot of blood going out, that means that normal and viable myocardium will get rid of the contrast material quite quickly. Now, areas that are dead, that are infarcted, will not be able to enhance the contrast material because they don't have a blood supply anymore. But through diffusion, they will be able to take up some of the contrast material, And due to the fact that they don't have any proper veins because they're dead, that contrast material will remain within that area. So that's what we call late enhancement, because from administering the contrast material, we wait 15 minutes, and any area that remains white is dead. It's that simple. And the normal myocardium will remain black on these late enhancement images. Here's a broken-hearted syndrome, which is also quite interesting. So here's a 70-year-old female who had elevated necroenzymes and accompanying ECG abnormalities, but the test results came back negative, meaning the coronarography was negative. So MR was again requested for, and let's not forget that this is the apex of the heart and this is the basal segment of the heart. So again, if we're looking at the sign image, the blue arrow is pointing to the fact that the middle and the apical third of the heart looks kind of lazy, looks like it's not contracting properly. So now let's look at the T2, and you can see that those areas are quite bright on the T2, meaning that there is a lot of edema. So again, the suspicion for an infarct is quite high. However, when we perform the late enhancement images, it seems that all of this myocardium is normal. It just has been affected by this trauma, meaning that the patient caused the MR abnormalities. So this is proof that our brain can actually affect our bodies, because a lot of these patients with a broken heart syndrome suffer a serious psychological trauma, or they go through a period of depression, and they can have heart symptoms, and as you saw, necroenzyme and ECG abnormalities as well, but the MR is diagnostic that they don't have an infarct. Myocarditis is a very serious disease, and here is this 17-year-old with elevated necroenzymes and ECG abnormalities. Coronarography was performed, but the test result came back negative. So we again give the patient contrast material, but we don't wait 15 minutes because we don't want to know the late enhancement for now. We are just interested in knowing how well the myocardium enhances at first pass. So that means that a couple seconds after contrast administration, and you can see that the myocardium enhances quite homogeneously. There are no defects on this myocardium, so this is normal. However, if you're looking at the T2, you are looking at areas with increased signaling edema to you. However, this edema doesn't affect the subendocardium, so the area that's closer to the chamber. Now, if we perform late enhancement, so we give contrast, we wait 15 minutes, and then we image the patient, you can see that some of this myocardium is affected. However, this patchy type of enhancement, which again doesn't affect the subendocardium, is diagnostic for myocarditis. Chest pain and pulmonary embolism. So if a patient has if a patient is suspected of having pulmonary embolism, then we usually turn to CT and CT angiography in particular. However, if CT is not available, then the ER doctors will do echocardio. If there is no right ventricle overload, then PE or pulmonary embolism is highly unlikely. If there is, then they will try to get the patient into CT. And again, if CT is available, then CT is performed, and CT will either prove pulmonary embolism or it will disprove it. Now, it would be ideal if ER doctors started the evaluation of patients with these so-called decision rules. So instead of just throwing patients over to radiology to have a CT, they would start by asking questions, because it seems that if a CDR says that the patient is unlikely to have a pulmonary embolism, then that is reality. But I'll show you that in a couple more slides. First of all, let's begin by how ER doctors should evaluate patients. So if PE is suspected, then they should consult their little questionnaires. If those questionnaires say that PE is unlikely, then they could still ask for a D-dimer test, because the devil doesn't sleep. But if the D-dimer is also negative, then that patient can be sent home. If the D-dimer is positive, then CT can be performed. But please note that with just a couple simple questions and with a cheap examination, we can save a lot of patients from an unnecessary test and a lot of radiation. Here is a clinical decision rule that I talked about. So here are some of the questions that the ER doctors should ask. So did the patient, or has the patient had a previous PE? Is the heart rate above 100? Does he or she have active cancer? Are there signs of deep venous thrombosis? And so you add up these numbers, and if the number comes up to be higher than 4, then PE is likely, and you can send the patient over to CT. Now, I know that this is a very complicated chart, but just please bear with me. And so here is this study in which they enrolled a couple patients. Let's suppose that they were 800, and these were patients who were suspected of having pulmonary embolism. And so the doctors consulted 4 of these clinical decision rules or questionnaires. And when all of the rules said that PE was unlikely, they still did the D-dimer test, as I have described before, because the devil doesn't sleep. But then in 169 cases, the D-dimer was also negative. So the CDR said that PE is unlikely. The D-dimer also said that PE was unlikely. So these patients were sent home, and check this out. Out of 169, only 1 had a venous thrombosis and only 1 had pulmonary embolism. So this proves that a questionnaire and a D-dimer test can be used safely to rule out pulmonary embolism. Of course, medicine is not perfect, and there are losses that we have to live with. But I think that 1 venous thrombosis and 1 pulmonary embolism out of 169 patients is quite acceptable. So if you become ER doctors, please remember clinical decision rules before ordering a CTA. Here's what we see as radiologists. These are the defects. So this would be a pulmonary artery, which is almost completely filled with a thrombus on the right hand side. On the left hand side, you see the classical Oreo sign. So a white ring and a darker dot within that ring. Or on the lower images, you can see within the main pulmonary artery, or at the intersection of the main pulmonary artery, that there are a lot of defects, filling defects. And we can, on the right image, you can see that we can generate these virtual reality images, which is a little bit easier to understand for those who are not familiar with these axial slices. Aortic dissection is number 3 that we discussed under chest pain and under possible deadly causes. The chest radiograph has a very low yield for aortic dissection. We might suspect it if the mediastinum is widened or the aortic knob is widened, if there is pleural effusion, but it's very difficult. CT is much better because with CT you can see the intimal flap, so the border between the normal lumen and the abnormal lumen. You can also see that down here. So if you're taking the USMLE, watch out for this image. This is showing you aortic dissection with the true lumen and the false lumen and the intimal flap in between. Now, there is a special CT technique. It's called triple-rule-out CT, with which you can rule out or confirm myocardial infarction, pulmonary embolism, and aortic dissection in just one sitting. Now, the thing to remember is that triple rule-out CT is not available at every department. And as a clinician, if you suspect pulmonary embolism, the CT technique will be completely different than if you are telling the radiologist that you're suspecting an aortic dissection. So please remember that for every clinical question, a CT protocol might exist. And if you're doing a pulmonary embolism CT, then with that, you might not be able to assess the coronary arteries and vice versa. However, with triple rule-out CT, if available, you can rule out 3 different diseases in just one sitting. So triple rule-out CT is good for patients who have atypical chest pain and in whom acute coronary disease is less likely, or who have a negative troponin level and myoglobin level, or if the ECG is normal or non-specific. So here are some images of younger patients who have significant disease. So this patient has significant stenosis on the left ascending coronary, and later on a stent was placed, but that's not shown. Here is a 31-year-old who has pulmonary embolism, significant pulmonary embolism on the right-hand side and even on the left-hand side as well. And here's a 79-year-old patient with chest discomfort and pain, and he or she suffered a type B aortic dissection. Please know that the American College of Radiology has these so-called appropriateness criterias. So for a given clinical condition like acute non-specific chest pain and low probability of coronary artery disease, they have a list of imaging modalities which might be appropriate or not. If the number after the imaging technique is between 7 and 9, then that's appropriate. If it's 1 to 3, then it's usually not appropriate. For acute non-specific chest pain, a chest X-ray would be appropriate, or CT angiography would be appropriate. For a patient who is suspected of having pulmonary embolism, a chest X-ray might be appropriate if you are suspecting some other causes like a pneumothorax or pneumonia. And if you have ruled those out, then you can move on with the CTA. But first of all, as written here, you should first apply the clinical decision rules. If your patient is pregnant, then you should wait with CT as much as you can possibly wait. You should instead perform a Doppler ultrasonography of the lower leg or order a chest x-ray, because the chest x-ray might show you indirect signs of pulmonary embolism. Here is suspected aortic dissection. Here it says chest x-ray as 9, probably because it doesn't mean too much radiation for the patient, and with a chest x-ray you can also rule out other causes. But CTA, so a CT examination with a lot of contrast to fill the arteries, would be your best bet in case of aortic dissection. Just a slide on COVID-19 and radiology, because when I'm recording this, it's 2020, and in Hungary and all over the world, we are looking at the second wave of COVID-19. So you might have heard that CT has some suggestive features of COVID-19 pneumonia, but the thing to keep in mind is that CT should never be used to screen for patients with COVID-19 or to replace the PCR test. However, on CT images that were ordered for other reasons like dyspnea, trauma, pulmonary embolism, etc., we might see classic signs of COVID-19 pneumonia. And here are two images that were proven COVID-19 cases. One of them came from Canisi Hospital. So the top image is showing you these dense peripheral consolidations, which are quite symmetric. They are affecting both lower lobes, and the lower image came from a journal article that is showing you these round ground glass opacities, which are also affecting both lower lobes. And if you're curious about the typical, indeterminate, and atypical signs of COVID-19 pneumonia, I have prepared a presentation for the European Society of Radiology, which is available on YouTube, and you can watch that. Now, lung cancer, which is also a very important part in thoracic radiology. So annually, lung cancer kills about 4 million people worldwide, and it is responsible for 1/3 of all lung cancer deaths. Small cancers have a relatively good survival rate, so we should definitely try and screen for lung cancer. Here is one of my favorite cases of all time. There was this older man who was a heavy smoker, and he had one CT study in 2013 on which they saw this right upper lobe somewhat spiculated nodule, and he was ordered to come back a couple months later to assess for progression. He never showed up, only showed up in 2017 when the complete right upper lobe was atelectatic, and I believe that he passed away a couple months later. So the 8th edition of the TNM of lung cancer is relatively new, and it contains a lot of new information, off of which the main new information is that the T1 and the T2 have been divided up into T1A, B, and C. So now a T1A is a tumor which is less than 1 centimeter, a T1B is a tumor which is between 1 and 2 centimeters, etc. Now, between the 7th and the 8th edition, a lot of lung cancer screening trials have been done, and so the data that comes out of those screening trials showed that it's actually worth separating the T1s into 3 different categories because a T1 cancer has a different survival rate than a T1C cancer. Now, I usually ask my students in class that if they had unlimited amount of money and they had all the imaging modalities at hand, which one would they choose to screen for lung cancer? But the slide actually explains that. In the early 1990s, the National Lung Screening Trial was initiated in the United States. They enrolled about 53,000 heavy smokers. By heavy smoker, they meant that people who have been smoking cigarettes, 1 pack of cigarette per day for the last 30 years. These patients were offered 3 different examinations, so at baseline and then after the first and the second year, and they either received a CT, a low-dose CT with no contrast, or an X-ray study. And a couple years later, the shocking revelation was that people on the CT arm had a 20% lower lung cancer specific mortality rate. So meaning that they had a 20% less chance of dying from lung cancer. Here are 2 images showing you the difference between the image quality. So the diagnostic CT image utilizes about 7 to 8 millisieverts of radiation, and it shows the vessels in great detail and the bones, etc. in better detail than the low-dose CT image. The low-dose CT image utilizes about 1 to 2 millisieverts, but it's still diagnostic because you can still see this nodule over here, which is quite suspicious for cancer. So after the National Lung Cancer Screening Trial and a lot of other cancer screening trials in the US and Canada and some other countries, low-dose CT screening is now offered free of charge for heavy smokers between the ages of 55 and it's either 75 or 77, depending on where you go. In Europe, it is not yet recommended, but it is available. In Hungary, we are running the HUNCHES-2 screening trial, not to prove that low-dose CT screening is working, but to make it known for patients and to make it known for pulmonologists and to make the connection between patients, radiology, and pulmonology. Because once we recognize a lesion that is suspicious for cancer, we as radiologists have to have the connection to the pulmonologist, to the thoracic surgeons, so that the patients really do have a chance of survival. And just as a side note, you should know that Hungarians are leaders in lung cancer specific death rates, which means that out of 100,000, 51.6 will die of lung cancer. And this 20% might seem like a lot, which was, as I said, obtained from the CT arm, but quitting alone, so quitting cigarette smoking alone leads to a 40% lower lung cancer specific mortality, as was proven by this gentleman and his team in 2016. So lung cancer screening is, as I said, it's a non-enhanced CT kind of technique, which uses about 1 to 2 millisievert of radiation. As a reference, a standard CT uses 8 and a chest x-ray is about 0.1. The only drawback is that it generates a lot of images, so it's quite time consuming to read it. It's costly, and it induces a lot of false positive because a lot of nodules might be in the lungs because a patient had pneumonia and that's how the pneumonia healed. So that's why a lot of false positives are generated. The advantages is that it's actually high definition type of imaging, meaning that 1 to 1.5 millimeter slices are generated, and it's on those images it's very easy to detect abnormalities. CAD is available and we are actually using it, and it's interesting where the technology is going. In 2017, iterative reconstruction was shown at the European Congress of Radiology in Vienna, and they were showing us images, CT images, which were generated with the same dose as an X-ray study would have been done with. So I'm expecting that in about 5 years, X-rays will, well, if not eliminated, but they will have quite a low number of indications versus CT, because with that amount of radiation, we will be able to perform CT studies. Just to show you what I do when I am screening for lung cancer, I mostly look for nodules which are round or polygonal, less than 3 centimeter large opacities, which are either completely or partially surrounded by lung parenchyma. They are divided up into solid and subsolid types. Here is a nice white solid nodule which is showing spiculations. The other group are the subsolid nodules. Within this group we differentiate ground glass nodules, through which you can actually see the underlying vessels or bronchi, and the part solid nodules, which are kind of like the mixture of the ground glass nodule, and they have a solid component as well. And going from right to left, these nodules are less malignant. So the worst guy is the part solid, the bad guy is the ground glass nodule, and the guy who is less likely to be malignant is actually the solid nodule, even though the solid nodule that I'm showing you is spiculated and is actually a cancer. Now, when we're screening, we do a lot of measurements. We're measuring the nodules and we are consulting these very complicated charts. We don't have to know this. I'm just showing to you that, for example, if we have a patient who has a solid nodule at baseline screening, which is bigger than 6 millimeters but less than 8 millimeters in diameter, then we will order that patient back for another CT in 6 months. That's screening. And as I said, screening is done with CT, with a low dose CT technique, and we do not give the patient any contrast. However, if you have a patient who is suspected of having lung cancer, then you do a diagnostic CT with contrast. That's very important for you to understand. And here are some images to show you why we need the contrast. So there are many phases of lung cancer. For example, here is a central mass that's invading into the mediastinum. It's probably eroding into the wall of the trachea and some of the great vessels. Here is a peripheral tumor. Here is a large nodule which is surrounded by air-filled lung. Here is a peripheral spiculated nodule. Now, cancer, every type of cancer needs to be staged according to the TNM scheme. in which the T factor is largely depending on the size of the tumor, its location, and its surroundings. And the T stage can be answered with CT, but only if we have given the patient contrast. Because if you do not give the patient contrast, then a lesion and the heart or the great vessels next to it would be the same color, and you couldn't differentiate the cancer, you couldn't measure the cancer, so that would be a useless examination. But if you give the patient contrast media, then you can answer how big the tumor is, whether there are any pathological lymph nodes, and you can either assess for metastasis. Here are some other cancers, lung cancers: cavitating mass in the right upper lobe, a consolidation on the left, ground glass opacity on the right, and mixed ground glass and consolidation next to the heart. Here are some examples of T stage. So on the A image, you can see a nodule which is less than 3 centimeters. So this is a T1. You don't see it, but there is an endobronchial mass which causing right upper lobe atelectasis. You can see the atelectasis. That's what the white arrow is pointing to. And the black arrowhead is pointing to the expected position of the endobronchial mass, because you can see that the bronchus is suddenly terminated. So beyond that would be the endobronchial mass. On image C, you can see a T2A cancer, which is less than 4 centimeters but greater than 3, and a T3, which is less than 7 but greater than 5. Now, CT doesn't allow us to assess for mediastinal pleural invasion, which would be a T3, because with CT, the only thing you see is that the cancer has eroded into the mediastinum, into the mediastinal fat plane, and that's a T4. If it infiltrates the diaphragm or the carina, that's an automatic T4. And again, with CT, you can assess these. But in some situations, MR has to be utilized because CT fails to answer the question. So, first of all, here, we weren't able to tell if there was any rib invasion or not, and MR proved that there is no rib invasion at all. However, the main question here is whether there is invasion of the chest wall, and with CT, there's no way to tell that. But since MR has a better contrast resolution, so to say, then with that we can prove that this cancer, which is enhancing at its periphery, is now way beyond the expected contour of the right upper lung, the right lung apex. And on the very far right image, you can see that the cancer doesn't invade the mediastinum, in which case this would be a T4 cancer and thus inoperable. So MR really helps us in differentiating a T3 and a T4 type of cancer. Now, another problem with CT, as you have seen before, is when you have an atelectasis and an endobronchial tumor, then they cannot be told apart, so you cannot measure the primary cancer. In these cases, FDG PET can help us, because then atelectasis wouldn't take up the FDG. However, the tumor would show up nice and bright. And MR can also help us, because you can see over here that on the T2, the atelectasis is white, but the cancer itself is dark. So you can actually perform measurements on these images. The TNM is of course important because it allows us to better allocate patients who are eligible for surgery and to reduce unnecessary thoracotomies. The best modality would be CT, but it's not widely available and it's quite expensive. The TNM is constantly evolving because there are better surgical techniques coming up and better oncoradiodiagnostic techniques. And diagnostics of lung cancer is mainly carried out by bronchoscopy and CT. And you can see here that based on the stage, you can either resect the cancer or you can only offer palliative chemotherapy to the patient. Here is the survival rate depending on the stage. So if you have a cancer which is quite small and there are no lymph node metastases, then the patient is 1B, and 1B has about a 70% chances of survival, 5 years of survival. However, if the patient has distant metastasis, then that's an automatic 4A, and he or she only has a 10% chance of survival. Lymph nodes are very important to assess for, and the job of the radiologist is to identify the lymph nodes, tell the surgeon where to find the lymph nodes, and to report on the size of the lymph nodes. Here is the map that we use. Lymph nodes are categorized from 1 to 14. For example, the 2R would be the right paratracheal, the 2L would be the left paratracheal lymph nodes, and they are important depending on where the primary cancer sits. I would suggest you to take a look at this website where you can browse through an annotated CT study and you can appreciate the different stations that radiologists need to learn. Here is just one example where there is a pathological lymph node in the left hilum, and there's also one in the carina, because over here you can see the right main bronchus, to the left is the left main bronchus, so this would be in between the two, this would be below the carina, and again next to the lymph node is of course the esophagus. Distant metastases are also important because, as you saw before, patients who have a distant metastasis are automatically categorized into stage 4. If there is a separate tumor nodule in a contralateral lobe or a pleural pericardial nodule, that's M1A. If they are outside the thorax, that's M1B, and if there are many extrathoracic metastases, then that's M1C, and they have a 0% of survival regarding 5 years survival. When CT is performed for lung cancer staging, then the examination is carried out from the lung apices down to the lower pole of the kidneys, because lots of times lung cancer metastasizes into the liver and to the adrenal glands, and here are some examples. So let's take a look at the right-sided image first. You can see these enhancing grounded nodules in the liver. There are many of them, at least 4. These are metastases. There is effusion, free fluid in the abdominal cavity next to the liver. That's also not a good sign. And on the left-sided image, if you look at the left kidney is displaced by this large, heterogeneous, mostly hypodense lesion, which is suprarenal gland metastases. Distant metastases are also very common in the brain. Now, CT is utilized mostly, but CT doesn't have a good diagnostic yield, and here is just one example. Image C is a non-enhanced brain CT. D is a contrast-enhanced brain CT. None of them show any abnormalities. However, the same patient was imaged with MR, and you can see these tiny white dots all over the place that are due to small metastases. So this patient wasn't healthy in a sense that he or she didn't have any metastases. He or she just had 2 small metastases for CT to be able to diagnose them. MR is also good for looking for bone metastases. Usually scintigraphy is performed to look for bone metastases, but if you look at the image on the left, you can see that there's maybe 1 or 2 foci that are suspicious for metastasis. If the patient goes into the PET scanner, then additional foci of metastatic bone lesions are revealed. However, whole body MR is the best because it'll show the most, it is the most sensitive for bone metastases, and it'll show you the most lesions of the same patient. So this is the same patient who underwent scintigraphy, PET study, and a whole body diffusion weighted MR image. Thoracic interventions can either be guided by X-ray, ultrasound, or CT guided, and they are done at the radiology department. So in terms of the thorax, we usually take a biopsy out of nodules or single site metastases, or we can perform embolization of lesions, put coils into arteries or stent them, and perform selective lysis. But these are very uncommon at my hospital. Now let's talk about just one sentence about the dose. So a chest x-ray is about 0.1 millisievert. If you perform a non-enhanced low-dose CT for screening purposes, that's about 1.5 millisievert. And if you perform a full diagnostic CT with contrast for staging a lung cancer patient, that's at least 7 millisieverts. Let's quickly talk about RECIST, which you might have heard about in oncology. So the goal of RECIST is to objectively measure response to therapy. So the thing is that a lot of oncological patients receive good treatment, and they will live much, much longer than they would have lived 5 or even 10 years ago. So we need to be able to objectify their disease and to objectify the response to therapy. We either use CT, MR, or PET. On the images, we need to select so-called target lesions, a maximum of 2 lesions per organ. So let's suppose that the patient has 2 liver metastases, and we select them as target lesions because they can be measured nicely. We will measure their greatest diameter, and we would add up those values, and that would be our reference value. All other lesions, which are non-target lesions like pleural effusions or bone metastases, those cannot be objectively measured at CT or these cross-sectional imaging studies. So we call them non-target lesions. We report them, but we do not put a number to them. Lymph nodes are measurable, so they can be a target, but we measure their smallest diameter because their smallest diameter correlates best with their dignity. So lymph node which has a smallest diameter less than 10 millimeters, that's considered normal, versus a lymph node which has a smallest diameter that is greater than 10 millimeter, that's considered to be pathologic. So the idea of recyst is that, let's suppose that you have a patient who has been diagnosed with unresectable lung cancer. So you perform the initial staging study, you pick out the target lesion and maybe some other lesions like lymph nodes and liver metastases, etc. You measure their greatest diameters, you add up those numbers, and then that's your reference number. And then the patient receives some form of chemo or radiotherapy, whatnot, and then another CT is performed. Then you go back to the original study and you compare how much each of those lesions have changed. If everything disappeared, then by RECIST standard, you call that complete response. If there was a greater than 30% decrease in your reference number, then that's partial response. If nothing has changed, then that's stable disease. And if there is a greater than 20% increase, then that's progression. Now, please note that if the increase was less than 20%, then that's stable disease. And if the decrease was less than 30%, that's also stable disease. And I think that this is an extraneous slide, so I will not read through this. Instead, let me give you some examples. So these are target lesions. This is a target lesion in the liver. This one is in the lung. This is a lymph node in the abdominal cavity, which measures 32 millimeters by 25. So these are targets. And the lower two are non-target because you cannot really measure gastric wall thickening properly or precisely, and you cannot really measure bone destruction precisely. Here is an example of a stable disease in which the decrease in diameter was less than 20%, and so that's not enough to call it partial response. We call this stable disease. Here is unequivocal or obvious progression when the lung cancer increased so much that you call this obvious progression, even though you cannot really measure this this area, which is the cancer itself. And RECIST is also important because some drugs require the radiological report to include RECIST. We actually do this on a daily basis. So we report according to RECIST criteria. And we have arrived to the last topic of this talk, which is the mediastinum. Chest X-ray is utilized the most to assess for diseases of the mediastinum. However, due to the nature of the chest X-ray, due to the fact that a lot of things are overlapping and some lesions hide beyond normal structures, then it's no wonder that it yields the least amount of information. CT and MR are the best in this sense. And of course, transbronchial ultrasonography or PET-CT may also be helpful for us. Now, this is the latest classification of the mediastinum, which divides the mediastinum into 3 different compartments. I'm going to jump back and forth between this slide and the next one. So first of all, here is the prevascular compartment indicated by this purple area. So it's the upper border is the thoracic inlet, the lower border is the diaphragm. It's situated behind the sternum, and it is in front of the pericardium as it wraps around the heart in a curvilinear fashion. It contains the thymus, fat, lymph nodes, and the brachiocephalic vein. And thus, lesions that might happen here are cysts, thymic carcinomas, lymphomas, thyroid enlargement, and teratomas. The visceral compartment is this blue area, so it's behind the pericardium, and it's in front of this line which crosses each vertebral body, but it crosses them 1 centimeter behind their most anterior aspect. And as you can imagine, the trachea, the esophagus, the heart, the great vessels reside in this area, and thus lymphadenopathies, tracheal lesions, esophageal tumors, vascular lesions are the most common. However, some interesting cysts might also reside in this area. And then the yellow area is the paravertebral, where hematomas and neurogenic tumors might reside. Heaven forbid you become a radiologist, you will have to learn the cross-sectional anatomy. I will leave you with this because a lot of people require some amount of time to fuse the drawings onto these radiological or CT images, but trust me, they are the same. And yes, whatever is written here, like the aorta, this is the aortic arch, is actually this anatomical entity over here, and this bright white area which contains the iodine containing contrast media is the superior vena cava, because this patient probably received the IV contrast through his right arm. Okay, and as a radiologist, here's how we characterize lesions. First of all, this is how we characterize mediastinal lesions. We rely mostly on what I have described to you. So these three compartments. So cysts are the easiest because, and this is figure 4 on my slide. Figure 4a is a CT image. You can see that in the prevascular compartment there is this homogeneous oval-shaped structure with sharp contours. And if I were to measure the density of this structure, I would measure water because this is a cyst. If I perform the T2 weighted MR image, then on the T2 it's bright white because it contains just water. So this is a cyst. By location, I would know that the thyroid gland would reside over here, or it would be connected, or this lesion would be connected to the thyroid gland. So this is goiter, and it contains some darker areas which are cystic components and some white stuff which is a solid component. So this would be an easy diagnosis. This would be a little bit more frightening to look at because it seems that this mass is invading the mediastinum, the interior thoracic cage as it is, and it contains some fatty areas, this really dark area. You can see that the color is almost the same as this subcutaneous fat, and it also contains some fluid, but due to the fact that it contains fat, it is, and the fact that it's in the anterior mediastinum, it's probably a teratoma. Now let's move on to the middle part of the mediastinum. Again, a cyst is an easy diagnosis. If it's closer to a bronchus, then we call it bronchogenic cyst. If it's closer to the esophagus, we call it an esophageal duplication cyst. Either way, they will be resected. Esophageal cancer is again an easy diagnosis because the wall is usually unevenly thickened, and as esophageal cancer is usually quite advanced when we recognize it, so there would be invasion into the neighboring structures. A cardiac angiosarcoma is also not a difficult diagnosis. It lies within the pericardium, and you can see that it's pushing against the heart, so it's causing a lot of mass effect on the neighboring structures. And then the paravertebral component, you can see on the right hand side, highlighted by this white arrow, neurogenic neoplasm, which sits next to this vertebral body. And on the lower right images, you can see bony destruction and the soft tissue mass surrounding it. This was cystitis or osteomyelitis in a 62-year-old female. And this is it. This is the end of my presentation. I hope you have learned a lot. If you have any questions, I will answer them now, or you can email me. I will see you next week for my abdominal radiology presentation. See you then.